First of all, I think I'm a little crazy for choosing this topic, but as I was talking to Dr. Windles on the way over, when you're in primary care, coming up with a grand rounds topic is not that easy because a lot of the things that we treat, or everything we treat, is also things that subspecialists treat. And so I wanted to come up with something that was a little bit, a little bit off the radar for people. And I could have started out by saying, we're going to have Grateful Dead and Jefferson Airplane and have a tie-dye shirt on. And I actually almost used the advice of two of my male GIM colleagues, and that limits it quite a bit. Dan Solmacy he's not the one, so you figure it out, who said that, when you're introducing the topic of psychedelics, you just tell everybody to reach under your seat before you get started and see what's down there. And so, but I'm not going to do that because this is a very serious topic. And I think that it's the so-called psychedelic renaissance actually began around 2006. It's been growing. There are now at least 3 or 4 centers in the United States, mainly Johns Hopkins Center for Psychedelic and Consciousness Research right down the road. And what really struck me when I first started reading about this was the science behind it. It isn't just something that is a drug experience that kind of got out of control in the 60s. A lot of the researchers that started back in the 50s were these very, very rigorous and actually very cynical scientists who wound up getting back into the research field in 2006 when the FDA allowed these drugs for use again in experimental protocols. So this is depiction of the so-called magic mushrooms. The picture itself kind of, I think just depicts what the people at the time were thinking and experiencing when they took these medications. These are very potent agents, as are all the psychedelic medications. And that one of the things that I'm going to try to get across today is that, one of the most important things about the drugs is the way they are administered, the protocols, the format which they are delivered. And so it's going to be about efficacy. It's going to be about safety. And we're going to talk primarily about, I guess the main psych disorders would be depression and anxiety, PTSD, addictions. And then one that particularly is interesting to me is the so-called existential distress associated with people with terminal illness. And so a lot of the studies have done and looked at these main topics. What I will say and not talk about are other ones that I'm interested in. Eating disorders, to me, are probably the most hardwired, difficult to treat psych disorders. And Hopkins does have studies going on now for that, for OCD, and they've even opened up studies for Alzheimer's disease, which I think is also kind of fascinating. So, and there we go, right off the bat, which is the, come on.
Just use the mouse on the screen.
Oh, yeah. Oh, there you go. Okay. So, so this is the topic today, and it's going to be primarily psilocybin-assisted psychotherapy, although there are other agents that are done. And some people describe these sessions as, basically an advanced form of CBT. So the people are actually having a therapeutic session. It's just that these agents are stimulating a lot of the fears, aggressions, concerns that patients have and come to the surface a lot quicker. Somebody had commented that Freud said that the road to cure was through the unconscious. Dan Solmacy will probably correct me on that. And if that's the case, then these psychedelics are kind of the super highways that can actually make some new neural connections that have meaning for a lot of people. So again, using the same topics here that we're going to talk about, the guardrails are probably the most critical piece in terms of therapy. And we'll talk a little bit about how things went off the rails many years ago. What we also are not going to be talking about, which is, and it's pretty hard not to mention it are things like mystical experiences, people that have a transcendental response to these drugs. And in fact, in some of the things we're going to talk about, particularly addictions, it's probably one of the mechanisms that leads to success in their treatment. Okay, so disclosures, none. However, you might be wondering if this young lad in the fall of 1969 as a freshman might have had some experience. As far as I remember, there was none. I was a good Catholic boy who had this very, very strong guilt thing, but I was very much attracted to the intellectual people who were experimenting. So as far as I know, I am completely psychedelic free. But I am what they call a psychonaut, which is basically a person who has a strong interest in the field. So as far as a little historical background, so I think everybody knows that for centuries, if not millennia, indigenous cultures, particularly in Mexico, areas of North and South America, have been using potent psychedelic agents as a sacramental rite in treating various things, everything from healing illness, people that are impacted by critical events in their life, and then also just a community interconnectedness, which these things seem to have fostered over the years. And really, and I mentioned a couple of the different drugs, so psilocybin is the one we're going to talk about most. Mescaline, these are all naturally occurring. So mescaline from peyote, LSD was originally from an ergot fungus. I told you I wasn't going to talk about microbiology, Joe, but the fungus is in there. And then DMT, which is from, I think it's like the salivary gland of toads. Interestingly, as an aside, my son, who's a firefighter in Philly, called me last night, and he knew I was doing this talk, and he said, "Hey, Dad, what's a deal? What's a deal with some of these drugs? My friends at work are doing them. One's got some letters in it." I said, "Well, LSD? No, it's not LSD." And it was DMT. And so I'm not going to talk about DMT, but it's one of those psychedelics that is, it's sort of considered like blasting off into space in a matter of seconds or minutes. So it's not something that would be recommended recreationally or probably even under ideal clinical circumstances. So it makes me a little concerned about the Philadelphia Fire Department. These didn't make their way to the US. They probably did, but I mean, underground, there was probably some activity. But the person who is most linked to the beginning of the psychedelic movement in the US is Albert Hoffman, who was a researcher at Sandoz, who accidentally discovered LSD. And as he put it, it found no clinical value when they used it in animals. And my first thought was, can you tell if a cow is dissolving its ego? I don't know. But it was shelved for many years. And he was asked to re-explore it because they were looking for an agent. It's an ergot alkaloid, and they were looking for some marketable drug. And he actually had a tactile experience with it. He didn't actually take the drug himself initially. And after having just tactile exposure in the lab, he had what he described as, quote, unusual sensations, kaleidoscopic colors. And then later on, when he actually took the drug, because he was the one that synthesized it, orally, he had this feeling of oneness, which is one of the things that you will hear a lot in people that have had drug use or experience with some of these agents. Interestingly, I know we're a Jesuit institution, but the emergence of the Catholic Church after the Spanish conquest really drove a lot of this underground because it was obviously considered a pagan religion. And it really wasn't a religion, but it was kind of, like I said before, it was kind of like a sacramental thing that people were doing. So most of the healers or shamans or whatever you want to call them basically were working underground for many years. And it was really through these guided therapists, if you want to call them that some of our initial psychedelic pioneers learned a little bit about the drugs and the drug experience and the methods by which to study them. So I think it's interesting to find out, where this all came from. And then the question is, why would I want to talk about this and risk my reputation about psychedelic medications? Well, as Dr. Ayub said, I really do have a strong interest in treating mental health disease. I think they've been stigmatized, most of these people have been stigmatized almost all their life. And those of us in GIM in particular are very, I think, attuned to treating these diseases. And it's not a knock against psychiatry, but we don't have access to psychiatry the way we would like. And so if we don't learn how to treat these disorders, then our patients are really going to suffer. So we do a pretty good job, I think. And what I would say, though, and I don't really say this in my lectures, although I sometimes will, most of the studies that looked at drugs like SSRIs and SNRIs shown they're better than placebo, but not by much. And so some of the comments are that at least 50% of people on these drugs and other drugs, such as, bupropion, will remit with their depression. Not only that, these are drugs they have to take sometimes lifelong, a minimum of a year, and they're taken every day orally. They do have potential side effects. And so while I do think, I put on here what was going on in 1986. So when I finished the program here in 1986, the treatment options for depression were TCAs, MAO inhibitors, some benzos like Valium and Librium, and lithium. And all these drugs are toxic. And if you didn't know how to use them, or even if you did use them properly, they were filled with side effects. So I will say that the emergence of the SSRIs and SNRIs were a huge advancement in treating patients. What we don't do a lot is ECT. Obviously, you're not going to do ECT on a patient who just has, regular depression, but it's probably the most effective treatment for depression. And then I'll give a shout out to Georgetown. They did come up with the transcutaneous treatment, TMS, for depression, which interestingly, when I went back and looked at their grand round slides, some of their mechanisms by which they work are not too far off biologically or neurologically with the psychedelics. So for those of you who do treat depression and other primary mental health illnesses, that's an option if somebody's failed a number of medications. So we have come a long way. So goals for today is want to review the research data as best we can. We're going to talk a little bit about the limitations of research as well. And to talk a little bit about the people that were involved in this, and to understand that while it's still early in the research, these are potentially game-changing paradigms to treat mental health. So I think you should take it seriously. I hope that at some point in time we'll be able to, they're projecting that psilocybin and MDMA are going to get approval, or they're going to be taken off Schedule 1 sometime in the next year. At least that's been the projection. At which time I think more research can be done with these drugs at other institutions other than the ones that I mentioned earlier. And we'll talk a little bit about the mechanism of action. And we'll also talk about the potential for both expansion of neurologic networks, but also we'll talk a little bit about the potential for problems or side effects. Busy slide, as always. Murphy does everything 5 times longer than everybody else, I'm the opposite of Mike Adams. We used to have this thing where he could say the same thing in 3 words. But I'm going to go through, there are literally hundreds of people that were very much involved in the whole Renaissance period. I'll talk about 3 of them briefly. We mentioned Hoffman already. He actually lived to be 100, so I guess there's not too much toxicity with the drugs. He was the one that actually, when they restarted the workup and the production of it, it was actually sold. I guess I wasn't around. I was around in 1960s, but I didn't know anything then. I was just a little kid. It was actually marketed as a drug called Delcid, and so you could go to your doctor and get a little acid for your medical problems, I guess. When things kind of collapsed later on during the 60s, obviously all this was shut down. But in the process of working this up, he really was one of the early pioneers that determined the effect of serotonin on mental health disorders. And so indirectly, he's not credited for coming up with the SSRIs or SNRIs, but he was one of the early researchers that developed the so-called mechanism of action, how they work, the pathways, et cetera. So we do owe a good debt to Hoffman. In the order that it's here, I'm going to skip over the two serious scientists that are on here to skip to Timothy Leary. So how many people here have heard of Timothy Leary? Cassie, you never heard of Timothy Leary? All right. All right. Well, Timothy Leary was a bona fide, reasonably well-respected Harvard professor, and he was actually involved in the early psilocybin studies at Harvard. And he was a little overly enthusiastic. A lot of his studies involved his own, not students, but I think his fellows in psychiatry, and which was a sort of an ethical question as well as like, do you actually take the drug that you're going to be researching? And what really went off the rails for him was he felt very strongly that these drugs should not be restricted to just mental health problems. He felt that the mind expansion, et cetera, kind of benefits should be utilized by everybody. And so in the 1960s, and particularly in the San Francisco Bay Area, where they were doing the so-called acid tests, where thousands of people were experimenting with LSD, he pretty much sold out the whole movement. All the research that had been done in the 50s and early 60s was just wiped off the map. It closed down. And as I put here, Richard Nixon called him the most dangerous man in America. And as we know, he was really the most dangerous man in America. So Timothy Leary, actually, a little footnote to him is when he died, he was like the guru. He dodged a lot of legal things. I think he was indicted a couple of times and convicted. He actually, when he died, he had his ashes shot into outer space. So he was truly a space cadet, both on the ground and in the sky. The two other people that I'll mention briefly are serious researchers. In fact, Roland Griffiths, who's the head of Johns Hopkins Center for Psychedelic and Consciousness Research, was very much a skeptic of these drugs. He was really kind of like a rigid scientist, and he wanted things to be done properly. But he became convinced with some of the early studies that there was some benefit to the drugs. He still wasn't completely on board, but as time went by, he was one of the original architects of the Renaissance back in 2006. And through his work, he was able to get huge amounts of money for the development of the Johns Hopkins Institute, which has allowed them to do a lot of the studies that are coming out. And he's still there. So if you're interested in signing up as a volunteer or a guide, you can do that. In England, Robin Carthyde Harris, he's probably the other most decorated or published writer these days. And his big thing was, I mean, like all the other ones, he was convinced that these were effective drugs. He was also very, very rigid as a scientist. His initial studies were primarily with depression and anxiety disorders. We'll talk a little bit about them. But he also was one of the first to do imaging, like functional MRIs on the brain of patients. You know, he did studies with placebo versus the brain on LSD or psilocybin. So he's very instrumental in looking at sort of the neural rewiring, the networks and things like that. He also was he was interested in this because he was a master's, I think it was a PhD or master's in psychoanalysis. He was one of the few people that believed that Freud was correct. but he didn't think that he had the way to get to the unconscious. And he thought that like free association was just not going to get him there. And the drugs allowed them to do that. So the mechanism of action. So this was all new to me too when I first started reading about this. By the way, what turned me on this topic was not so much the book by Michael Pollan, which is How to Change Your Mind, but an excerpt from that came out at least 5 years before the book was published in the New Yorker. It was called The Trip Treatment. And it was a lot of it was like a prelude to his book. I highly recommend reading it. It's filled with scientific information and a lot of anecdotal information as well. But I think the science is what we all need to know about before we can plunge ourselves back into using these medications safely. So partly due to the work of Hoffman, they found out that the so-called classic psychedelics, which would be their tryptamines, MDMA is not a classic psychedelic, but has similar properties. They have a high affinity for the 5-HT2A receptor, which is located primarily in the areas of frontal cortex, cingulate gyrase, basal ganglia, and parts of the limbic system. And so I have Dr. Motamedi sitting in front of me. He's going to make me nervous, but because when I talk about the rewiring in the brain, it's kind of like you have to dumb it down a little bit. It's very complicated stuff. But one of the things that has come out of the mechanism of action and some of the work by the other people is the incredible amount of network connectivity that goes on with these medications. And then physiologically, there's a decrease in blood flow and O2 consumption, primarily in the default mode. And that's the area that keeps us rigid. That's our, ego that's just like locking us into behaviors, some of them good, some of them not so good. And then one of the questions people ask is, well, how do you know it's not just a drug like cocaine? How is it different? You took a drug and you had a reaction. And I think one of the simple answers is the effect of these drugs on the patient. So if you snorted a couple lines of Coke and got really wasted, I don't think the next day you would wake up and say that they had an epiphany that, I saw the creation of the universe and it was beatific. And, so some of the reactions that you have with other drugs are really, truly side effects. And most of the stuff that comes out of the literature with psychedelics is kind of the other way around, with a few caveats that we'll talk about. And then continuing with mechanism of action, it's probably complicated, and I assume that it's a combination of some of these. There's different, they describe them as level 1, level 2, and level 3. And one is the cellular, one is the psychological, and one is the circuit component to the way these drugs work. I think probably all three of them are intertwined. We'll show you a couple of slides later that depict, this is not one of them, but I thought this was great. I forget the name of this artist. He was apparently a big psychedelic artist in the 60s. His last name was Gray. I forget his first name. But I mean, this picture just was, I really loved it because it was almost like a netter picture. You have pretty good anatomy, but you have a third eye and you have these kind of random electrical sparks going out somewhere into space somewhere. So I presume that this is a fairly accurate depiction of what some people go through. And again, the thing you're going to hear most, if the drug effect works, is the sense of oneness, connectivity, like understanding. And in fact, famous poet Ginsberg, Allen Ginsberg, apparently when he took his first trip, he wanted to call the president of China, Russia, and basically tell them all that they got to do this right away to basically heal the world. And then I think he just passed out somewhere, so didn't work, obviously. So we'll talk about the studies in a minute, but The main thing is the challenges, and I think they're huge challenges. We talked a little bit before about number one, it's not in the right order here, but these are still Schedule I drugs. These are not one. And I think that there are places in the U.S. where they're being administered fairly liberally, I think, but they're illegal to do so. Once they get the scheduling thing changed, they may be able to have, smaller clinic areas where they can hire guides and volunteers to work with the patients. I think that's the biggest problem. The other one is, how do you do a controlled? There are studies that are placebo controlled. Most of the placebo they use are drugs like niacin. I think Adderall has been used. It's pretty hard to do a placebo control. Most people know if they're getting a psychedelic drug. In fact, I think at Harvard, one of the studies involved the theological students, and it was a very small study, which is another one of the problems, as you'll see. And they gave like 15 of the students the active drug, and 15 got placebo, and the 15 that got nothing were sitting in the church going like, when is this going to end? Like we do when we go to church sometimes. And the other 15 were wandering around going, God is everywhere. God is everywhere. But these are small studies. We're talking most of them are like 20 patients or less. So it's hard, in terms of our rigid requirements for experimentation, it isn't easy. And the reason you're not going to get large studies, at least studies that are not just like virtual or, like reporting things, is the manpower involved. And we're going to talk briefly about what a so-called session is and what it involves. In the book, they describe them as flight instructions. So it's very well tailored. And so there's built-in bias because these people are told you're likely to have this, this, or this, or you're more likely to have certain things. So they have these certain expectations of the drug experience that can, I think, confound some of the results. But it's critically important that we continue as best we can to do the studies with the current guidelines and guardrails that I talked about before, because it's quite likely that things are going to revert back to the mid-60s again if we don't. And a lot of this research can be, once again, kind of buried for a while. So that's some of the studies that, and then we talked before about the things that we're going to talk at least briefly about are depression and anxiety, PTSD, end of life / chronic illness, fear of death. And then we're not going to go through some of the ones that I mentioned, but think there will be ideal drugs to experiment with. The drugs that we're going to talk about are going to be mostly psilocybin, a little bit of LSD, and MDMA. I am not going to talk about ketamine, which is a whole different thing. And there's some that seem to be better than others for different medical conditions. So there's a lot. I mean, you could go on each one of these topics. You could go on for a long time, but we're going to try to keep it relatively brief. So what does the therapeutic session look like? You'll see pictures. It's basically, let me get my water here. Sorry. Okay. So the last thing they want is to have it be in a hospital setting. The white walls. They want this to be in a relaxed environment. So most of the sessions take place in a quiet room. The patient can choose certain music if they want to. They all wear eye shades. It's usually nice art. Sometimes they have weird like mushrooms on the table. It just depends. But the point is they're in a comfy sort of situation. They have typically two guides. One who should be a trained psychologist who can interpret, or not interpret, but I guess work with the patient if they're having a rough start to their experience. But there's two of them, and it's a 6 to 7 hour session. So it's a long time. It's hard to enroll a lot of patients to do that kind of thing. After that, there's an integrative session. The following day, they come back and they meet with the team and they discuss what they experienced. And the therapist is there to try to make sense out of all of it. If somebody expressed or showed some really serious pathology, obviously they would be recommended to get ongoing therapy of some kind. But it's not complete until they try to put it together. And that's what the integrative session is all about. It's usually a one-time thing. So again, we talked before about an SSRI is basically, for some people, it's life. 3 strikes and you're on is the rule. If you have more than 2 recurrences of depression, you're pretty much on lifelong treatment. But, by the book, you should treat somebody for at least 9 to 12 months for their episode. And it's a daily medication. This is a one-time treatment with occasionally a second treatment. So it's not something they're going to be taking over and over again. It's a little bit different for addictions. I think they because these people are so rigidly adherent to these old habits that they often get, I'm not sure how the study design came out, but they often get a few extra doses up front. And but otherwise, that's it. Who's that guy? I should have wore this thing for last week's cat performance we had at our office. But that's what it looks like. That's actually me taking a nap. But it looks very comfortable, actually. All right, so we're going to talk a little bit about some of the studies, and one of them I think that's, I mentioned before this researcher in England his interest is in depression, anxiety, mystical experiences, but also was one of the original ones to do functional MRI. And not surprisingly, the imaging studies show a lot more activity in the areas of the brain that we talked about earlier. Doesn't mean necessarily that they're getting better, but I mean, one of the things that's impressive about it is just, we talk about a reboot, turn the computer off and turn it on again, right? Well, this is like similar to a reboot. I mean, these are people that have hardwired difficulty in life, often lifelong problems. And if there is some neuroplasticity available that can function and help patients, this may be one of the avenues where it can happen. Again, study size, very small. And this is just a few comments. And he actually, and actually, I think my comment where I think, because again, eating disorders I wouldn't consider myself by any means an expert. I only have a few patients with it, but they are, to me, the hardest patients I've ever treated in the psych world. We put people on a little Lexapro and they go, yeah, I feel better. They're not like jumping up and down and, being ultra creative, but eating disorders, nothing. They're blank. We got nothing for them. I mean, they go through therapy for years. They get hospitalized. They get put on occasionally fluoxetine or a drug like that. My sample number isn't very high, but the fact that these people, get into their 50s and older with these eating disorders demonstrates that they don't get better. OCD, similar thing. We do have drugs that work a little bit for them. And then addictions, which interestingly, addictions were the first things these drugs were used for. And if you go back in America at that time, when they were legal, politicians, actors were getting treated on a regular basis for tobacco and alcohol abuse. They were widely used. And while the studies, again, are pretty small, I think there's a slide here that shows that the 1-year cessation with a treatment was almost 70%. At 6 months, it was like 83% when using these drugs. And what's the best thing on the market now? What do you think the ballpark success rate is? I'll say Chantix is the drug of choice, but what's the ballpark success rate?
12%, 20 like that.
A little higher. Yeah, it's probably in the order of maybe like close to 25%, which is pretty bad, but compared to like nicotine patches and things like that, it was good. And then the interesting thing is, this is sort of the Oliver Sacks-ish version. The things like synesthesia, which is just fascinating when colors become tactile, or words become colors and things like that. That's some of the experiences. Almost all the people that take the drugs do experience some abundance of color or nature, and maybe that's part of the connectedness that they have. They often have sort of a sensation of being part of the world that they weren't before that. And then, the getting back to the default mode, one of Dr. Sharma's things that I think he talks about a lot when he gives you talks on these kind of things. These drugs can give you greater flexibility and make you more adaptable to things that normally are just so rigidly entrenched in you. So that is one of the areas where the drugs are actually quite active. I took this picture from, I don't know how scientific it is, but I just thought today on the way over, the one on the left looks like the former GIM chief's brain, and then the one on the right looks like the current chief without drugs. This is Murphy, like, yeah, it sounds like a good idea. Dr. Ayub is like, no, we have to have discussion about this. We have to, have a, I don't know. No, she's just very, very, like, she's on speed all the time or something. But this is sort of the depiction of what happens is, and it kind of correlates with some of the functional MRIs. Again, we don't really know for sure what this tells us, but it does indicate that there's networks that are interconnecting to some degree. And how that translates, other than the drug experience, we will find out as time goes by. So just in the past couple years, in fact, some of these articles in our main journals, JAMA, New England Journal of Medicine, have come out with head-to-head studies. So this one caught my attention. This was from a couple years ago. It was a trial with psilocybin versus escitalopram or Lexapro for depression. So they put it on the line. They had 59 patients, and I think they got 2 doses. Yeah, 2 doses of psilocybin 3 weeks apart versus 20 milligrams, which is max dose of escitalopram, actually, for 6 weeks. So it's obviously a small duration of time. I'm not sure why it was so short. And I got a blurb from the Hopkins network that I'm not sure it was this article, but I think it showed that these studies were actually becoming more, the same patients were enrolled, and that the benefits were actually turning out to be more positive as time went by. But I don't know what's going on here. This is like one of those games that kids play where they just put colors on. But the trend was there was no statistically improved benefit, but clearly, I mean, there was a trend towards improvement, and it was clearly non-inferior to what we consider standard therapy for depression at 6 weeks. And as there's all different like scoring systems for depression, but on the one used here, there was actually what appears to be a fairly significant improvement with the psilocybin without side effects. I mean, no significant side effects. And we'll talk a little bit about how there is generally a lack of that as other studies as well. The same year, Griffith and his group at Hopkins did an article that was published in JAMA Psychiatry, where they looked at psilocybin-assisted therapy. And I think it's important to remember that this is not just giving a drug. This is all being done under a therapeutic intervention. It's a way, I think, to sort of access the unconscious in a setting by using a drug that can release some of these things, which could be good or bad. So it isn't just like, hey, take this drug and let's see what happens and we'll study you. These are closely monitored. And in this study, which was actually small, but not that small, 27 patients, and there was a rapid decrease in depression scores from baseline, which again, was pretty short term, but it stayed statistically improved for at least 4 weeks and perhaps longer. and fairly dramatic drops in scores, and in actually 54%, there was almost a complete remission of depression symptoms. Again, these are not surprising because this was what some of the studies back in the 50s were sort of pointing towards, but they just didn't have the rigor that they're starting to have today. This is one of those, I told you before, that it's hard to do placebo-controlled trials because of the obvious benefit or the obvious effect that you would get with a psychedelic. They used 100 milligrams of niacin, which is probably just enough to give you a little burning, or just whatever. Forget what niacin. Sweats. Yeah, flushing. There you go. Thank you. This one was was a multi-trial over 11 different sites with a lot more patients. And again, statistically significant improvement, more and more little studies coming out that are just pointing to the success of these drugs. And I think, these are the kind of things that are allowing or making the FDA a little more flexible in determining whether or not these drugs can be rescheduled. This is an area that I don't do, obviously I don't do palliative care, but I have a lot of older patients. I have a lot of people with serious medical illness. And while you all are very young and you're probably not, you see death and dying all the time, but you're not personally feeling the fear that a lot of people have. Not something you ask a patient. Sometimes you might, but it's there. So these are people that are worried, and they're, we're ringing bells and things like that for successes, but a lot of people aren't having the success that we want. And so I think that I'm not sure how they come up with the idea to do this. I think they were just looking, they gave a sort of a situation where patients that have a serious illness have, basically feelings of hopelessness, which can morph into isolation, which can morph into suicidal ideation. So I think they were really looking at it as just a pure measure of whether it helps with the depression. But what they found was pretty shocking. Most of the patients in the studies just said it was literally the most gratifying and amazing experience that they've ever had. This was, it's been in the media. It was on 60 Minutes, and so it's not like a brand new thing. But some of the patients' comments were, while anecdotal, were still quite impressive. And most of them had a sort of a better understanding of their disease and what they're facing. Their depression scores went down, and they were more accepting of what was coming down the road. So I think that our palliative people at some point may be getting involved in some of this. Wake up, Amber. Ann O'Donnell used to do that to me, I think. So this is the same idea here. So yeah, talk about these people have depression, demoralization, etc. It's sort of a cascade towards deepening mood disorders, and breaking that cycle, I think, can be amazingly helpful. This study, it looked at these scores of the ones that they had at baseline, and they remained not only significant at 6.5 months, but at 3.2 and 4-year follow-up. So I guess some of them weren't that sick, but they were maintained over many years, even after they had 1 or 2 treatments with psilocybin. So this one kind of bothers me a little bit. So LSD, just by its name, is a problem. There's so much baggage with LSD that I think, even though it's a potent psychedelic that can have benefit, I'm not so sure that it's got a place if we have other drugs that are available. What one recent study showed that there's an increased use of this drug now, non-prescribed, by the way. people that I guess you can get, if my son can get DMT for the fire department, I guess you can get LSD somewhere. And if you do, it's obviously not using the methods and the things we talked about, which keep it safe. It's being done in the same way that it was done in the 60s, which as a party thing, or they could be out drinking, or maybe they're very depressed. So it showed that recently there's been an uptick in people taking these drugs non-supervised for depression. And they looked at, I mean, it's predominantly in younger people, not surprising given all the things that you read about and the pandemic and people just a lot of times dissatisfied and burnout and things like that. But it was also, I think in the study that it was more than 50% women that were involved. And it underscores the fact that these drugs are still out there and can be used in an improper way and not lead to the benefits that we think that are we're trying to achieve. And this is, that was a study, sorry, in JAMA Psychiatry this year, actually this month this year, with the sort of the breakdown of the demographics on the right. Most of them are like at least high school or college educated, with reasonably good income and a higher incidence of female. One of the things you'll see in almost all the studies is an underrepresentation of different ethnic groups. Didn't have access to these drugs even back in the 60s. Older patients. The patient I tried to send to Hopkins for her longstanding eating disorder was turned down because of her age. She was like 65 at the time. I mean, I think the original studies, they were kind of cherry picking people so they would get good results. Now they've expanded it and they are recruiting people at an older age. I think they have to, because we can't necessarily take these results and apply it to broad populations. So there's a movement right now to try to get a lot of different people, more women involved in the studies. Does it have any effect on younger women reproductively? All kinds of studies that are just not being looked at. So PTSD, I don't know what you guys see at the VA. I don't know if you're at the VA, raise your hand. Do they use meds there for PTSD? I mean, or is that just done under psychiatric? Yeah. Well, I mean, it sounds like the military and the VA system would be the ideal place to do this once the drugs get rescheduled. Most of the studies are using MDMA for PTSD. I mean, what are we using? Using like SSRIs and yeah. So it probably doesn't do very much, I would imagine. I mean, unless their primary problem is just depression. And MDMA is not a classic psychedelic, but it works on the same receptor, the 5-HT2A receptor. So it has similar mechanisms of action. It has less of the sort of the consciousness expanding, vivid colors, synesthesia type stuff that you would see with the classic psychedelic drugs. So it's kind of emerging as the drug of choice, at least in experimental studies. As you know, it goes under different names, Molly, ecstasy. It was like legal until what, 10 years ago or something? People were going out to rave and I didn't know what it was, actually. They all looked happy, sweaty. Dancing got better. Actually, no, I don't think dancing was better. Would have been great during the disco era. That's all I can say. I don't know. I don't remember when that was. Anyway, the main, I think, benefit is this enhanced sense of empathy. And again, who wouldn't want that? I mean, who doesn't want to feel good or, belonging to something? Even if it's a side effect of the drug, if there's not a lot of toxicity to it, maybe they can come up with a protocol where you can use small doses of this kind of thing. All this is being looked at. It also works a little bit differently. It works on other neurotransmitters like dopamine, which is obviously an important chemical in terms of mood disorders. Its only downside is it seems to work more on some of the peripheral serotonin receptors, and there's a little bit more of a problem with blood pressure and heart rate elevation. And I think in only a few cases, more serious cardiac arrhythmias. And again, you want to screen patients. You're not necessarily going to give these drugs to anybody who has, like serious coronary artery disease or heart failure and things like that. And most of the studies, it's done the same way. There's definitely like psychiatric support and therapy during the sessions. So I think it's an agent that will be emerging as one of the best treatments for PTSD, if not the drug of choice. Because right now, as you can see here, there's only 4 FDA-approved drugs. One of them is an SNRI, the other are SRIs. And I don't know how many patients I have with PTSD, but I don't think I have that many that I've recognized. But the ones that had it, I feel like I have to be really creative with the pharmacologic agents because they don't tend to respond to like standard doses of SSRIs. So, and remember that all this, just like psilocybin, is not just a drug. It's a drug-assisted psychopharmacology and therapy session. So when you use it together with those things, you can definitely see decrease in some of the scores that are done for PTSD. And again, not a whole lot of patients. This is going to be one of the big criticisms, but 90 patients in this one article that was in Journal of Psychopharmacology versus placebo. So again, not surprisingly versus placebo, but very encouraging studies that need to be followed up on as time goes by. Addictions, we talked a little bit about. I'm not going to go into great detail because I think, as I mentioned earlier, I think some of the mechanisms of action that are beneficial for addiction are not necessarily biological or molecular. I don't think they're targeting any particular, site. I think it is the experience that they have. And, some of the things, one guy called it getting dope slapped. He got treated, and he said he woke up and he was like, why the hell am I doing this? Like, I'm killing myself. This makes no sense. So there, again, it was just like this resetting of the brain in terms of like what we would say as a non-smoker, like, why does somebody do something stupid like that and spend all that money and, risk their health? But some of the experiences these people had just converted them almost overnight. And we talked a little bit in the 6 month after the psychedelic session, 80% of the study group were abstinent, and they were measured by CO2 levels and things like that. And it was sustained almost 70% at a full year. Now, you're just not going to see that in patients that we treat with pharmacologic, whether you use individual, like single drugs, or whether you use combination drugs, or whether you get CBT, it's just not gonna do the job. So they have ongoing studies apparently at Hopkins. It was just recently announced. I'm not sure. I guess they're going to do functional MRI to see whether there is something more to the so-called mystical experience or the default mode-ish problems that accounts for that. Some of the ways they describe it, and again, this gets into like the sort of the icky area of neurology, in that, just general terms like opening up a window of flexibility, which sounds really nice. I don't know, how you can prove that, but these people are transformed when they take the drug. And again, when it works, it tends to stick for a long period of time. The dope slapping is mentioned here. But again, I think people just have this epiphany that they come to understand that I'm losing my breath. Why would I want to lose my breath? I can breathe again. They have all these just very basic comments. I think I'm gonna skip the alcohol, not because it isn't important, but I think there's actually less data on this. In the book, How to Change Your Mind, it goes into great detail about the person who started AA. I don't think they use his last name, but he did his own psychedelic treatment, which he claimed cured his alcoholism. And then when he formed AA, as you know, it's sort of has sort of a religious kind of feel to it. You know, people that are powerless to transform their life now are asked to respond to a higher power type of thing. So a lot of people don't believe in the AA system. It's a little bit hard to get your head around. But again, the early studies looking at treatment for alcohol were mostly done on celebrities, people like that, and success stories looked very good, and they're now in the process of kind of looking at them again. So as you can imagine, these are potent drugs. There are potential downsides. I think they're very few and far between when it's done in the right setting. So again, set and setting are the two things. Set is preparing the patient, setting the scenario of what they're going to be experiencing. The setting being a comfortable, non-institutional environment where they can actually relax, listen to whatever kind of music, etc. There are some people that have this thing called post-perceptual disorder where they have sort of ongoing psychedelic kind of things long after the trip itself. And it's poorly understood, and Hopkins actually is enrolling patients now to look at this and get more information on it. There's fear about psychosis. In fact, I think Hoffman and people like that, when they were first looking at the drugs, were looking for a model of to treat schizophrenia. And there are people that are weeded out. They'll be eliminated from studies if they have a history of psychosis or bipolar disorder, at least at this point in time. Remember that time is it? 101. Okay, we're just about done. Remember, these are big issues that are coming up with these patients, and under the influence of drugs, they are going to come to the surface. The big thing about the guides is they redirect the patient. So if somebody's having what appears to be a really, really bad trip, they are there to like reorient them, tell them, everything is good, you're going to be fine. And so even people that started out with an obviously bad trip wound up having a much more and very evocative experience after that. All right, I just put the early fake news. They told us when I was in college they caused chromosome damage, and I have 4 kids. But then again, I didn't do the drugs. All right, real quick, closing thoughts.